Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. Now picture yourself in this scenario. Imagine you're cutting food or you're preparing food with a very sharp knife. And imagine that you end up cutting your finger. Now what happens in your body to actually arrest that bleeding or to stop that bleeding? These are the processes that we're going to discuss. Today we're going to look at hemostasis, and we're also going to look at the process of blood clotting. Over this review lecture video, we shall define a few terms and differentiate between a few terms. We shall talk about the stages of coagulation or the stages of hemostasis. We shall also talk about the coagulation as well as the fibrinolytic system. In other subsequent lectures, we shall look at some bleeding disorders which are of importance as well as some coagulation disorders. Remember that there are three important terms that you need to distinguish. The first term is hemostasis, the second term is blood clotting, and the third term is blood coagulation. Now, hemostasis doesn't mean the same thing as blood coagulation. Hemostasis doesn't mean the same thing as blood clotting. While on the other hand, blood clotting means the same thing as blood coagulation. So it's possible to have hemostasis without having blood coagulation. So hemostasis is just simply this mechanism that's going to lead to these series of reactions or these processes that are eventually going to cause cessation of bleeding from a blood vessel. Remember that this often happens spontaneously and it is a normal physiological response. So it's a normal physiological process. It's going to involve three important things. It's going to involve initial vasoconstriction. It's going to involve formation of what is known as the temporal hemostatic plug or the initial platelet plug formation. Then it's eventually going to conclude in coagulation of blood or formation of the definitive hemostatic clot. Now, if the cut is small enough, you could actually arrest the bleeding at the platelet plug formation minus you actually reaching blood coagulation, which means that for these two processes to happen, this process of initial vasoconstriction and this process of platelet plug formation, you need a few things to be in place. The first thing that you need to be in place is you have to have the correct number of platelets. So it means that if an individual has less platelets than usual, then their blood won't be able to undergo hemostasis adequately. If the person has platelets that are of normal number, but then there's something wrong with the platelets, is a defect with the platelets, then they won't be able to have normal hemostasis. So you collectively call problems that are going to be affecting formation of the platelet plug formation of the platelet plug as primary hemostatic disorders or primary bleeding disorders. Then you have disorders that are affecting the clotting factors. So if you have deficiency of those clotting factors, you get what is known as a secondary bleeding disorder. But of course, we'll talk of these bleeding disorders in much more detail. So with hemostasis, remember three processes: initial vasoconstriction, platelet plug formation, as well as coagulation of blood. And then on the other hand, blood clotting or blood coagulation pretty much mean the same thing. So this is the process of formation of a blood clot. Remember that blood is actually a fluid is a connective tissue in fluid form, and this connective tissue loses its fluidity and then it becomes like a jelly-like mass within minutes after it is shed out through an injury or it's even collected in a container that doesn't have any anticoagulants put to it. So remember, hemostasis is going to be initial vasoconstriction, formation of the temporal platelet plug, as well as the formation of the definitive hemostatic clot. I know this is a Pandora's box for many students and so many people don't like learning about this chapter, but it's actually one of the easiest chapters in physiology. So please pay attention. If you still haven't subscribed to the channel, please subscribe. The majority of people watching these videos aren't subscribed to the channel, so please subscribe to the channel. Hit the bell icon to get notifications every time I post. Drop a like, drop a comment to show support to the videos. Now, remember that hemostasis happens in three important stages or three important steps. The first step is what is known as the initial vasoconstriction. The second step is known as initial platelet plug formation, which I've already given a prelude to, and the third step is known as coagulation of blood. So remember that coagulation or blood coagulation is part of hemostasis. It's a process in hemostasis. So we'll begin with initial vasoconstriction. So going back to our scenario where you were cutting a food and you were using a sharp knife and you ended up cutting your finger, imagine that scenario, however painful it may be. So after you injure these blood vessels, they undergo this reflex that is meant to reduce the blood that is flowing to that area, because you don't want to keep losing blood, because you only have roughly about 5 liters of blood. So if you keep losing blood from your body, that's not a good thing. So as you injure the blood vessel, they undergo this initial vasoconstriction that decreases the blood flow to that area so that you can bleed less. But eventually there's going to be some vasodilatation that takes place. And remember that this initial vasoconstriction is basically happening in the arterioles. It's happening also in the small arteries, and it is due to 3 important things. Or you could think of it as 2 main important things. So it's due to either the spasm that you get in the muscles, so the vascular smooth muscles, because remember blood vessels have a tunica intima, which is the endothelium, a tunica media, which is pretty much the muscular layer of the blood vessel, and a tunica adventitia, or the tunica externa. So this local myogenic spasm, when you cut smooth muscles, they contract and they are going to decrease the blood flow to that area. And also you have some motocoids that are released. You can think of these as chemicals that are produced locally by the traumatized tissue, by some platelets, as well as some nervous tissue that are eventually going to also enhance the process of vasoconstriction. So remember that when you cut a blood vessel, you're going to be injuring the endothelium, you're going to be damaging these endothelial blood vessels, you're also going to be exposing collagen, because collagen is found underneath the endothelium, and you refer to that as subendothelial collagen. So when you expose this subendothelial collagen, the platelets can adhere to this subendothelial collagen, and once this platelet has adhered to this subendothelial collagen, it becomes activated. And once you activate the platelet, it's going to secrete things like serotonin. It's also going to secrete other vasoconstrictors that are eventually going to cause vasoconstriction. In addition to this, remember that this adherence of these platelets to this collagen is going to be mediated by a factor which is known as von Willebrand's factor. So this von Willebrand's factor is kind of like forms the mediator or the bridge that's going to be between a glycoprotein that is present on the platelet to the collagen fibers that have been exposed when you have injured the tissue. In addition to this, remember that the there's a neural reflex that's going to be happening that's going to result in a release of certain vasoconstrictors. Remember that these nervous reflexes are going to be initiated by pain nerve impulses, as well as by some sensory impulses that are going to be originating from the traumatized tissue that is nearby. Then you may also have these local spasms when you injure the blood vessel because of the contraction of the smooth muscles and the walls of the blood vessel. You may also release a compound which is known as endothelin from the injured endothelium. Remember, endothelin is a compound that's pretty much going to be causing vasoconstriction. So in conjunction with serotonin and other potent vasoconstrictors produced by the platelets, you also have endothelin, which is produced by the endothelium to cause vasoconstriction. And then eventually there's going to be that vasodilatation that's going to happen so that you can bring more platelets, you can bring more clotting factors to the site so that you can actually seal off the injury and begin to repair the damage. So the next step that we're going to move on, after you have this initial vasoconstriction, you then later on move on to platelet plaque formation. Remember, platelets are going to undergo 3 main processes. They're going to undergo platelet adhesion, they're going to undergo platelet activation, and they're going to undergo platelet aggregation. Remember the properties of platelets, the 3 A's: adhesion, activation, as well as aggregation. So remember that whenever there's an injury, what you are exposing is subendothelial collagen. So I shall keep using subendothelial collagen throughout this lecture, and I think you'll get tired of it. So there's some subendothelial collagen that is exposed. Once the platelet actually comes into contact with the subendothelial collagen, it begins to undergo certain characteristic changes. So one thing that happens is that these platelets are going to swell up and they're going to have an irregular shape. So after them having this irregular shape, then they're going to develop these cytoplasmic extensions, which are referred to as pseudopods, which are just these protrusions that are going to come from the surface of the platelet. So you produce the pseudopods. And remember that the platelets themselves have some contractile proteins. They have actin within their cytoplasm. They have other contractile proteins that are eventually going to contract, and they're going to be pushing the granules that are present inside the platelets so that the could release whatever is stored in the granules. And two important things that are stored in these granules are adenosine diphosphate, or ADP, as well as thromboxane A2. I'll explain where thromboxane A2 comes from. And these two substances are going to be eventually going to activate other platelets, and they're also going to enhance the process of platelet adhesion. So remember that this ADP as well as thromboxane A2 are going to pretty much attract more platelets, and they're going to activate other platelets. Now, the stickiness of these additional platelets kind of like creates this vicious cycle whereby you activate a platelet, it activates other platelets, it activates other platelets. So it keeps going on and on and on and on, which is why if you do not have some brakes on this system, you could actually go on, and actually your entire bloodstream would be filled with a lot of clots. So there is a mechanism that is put to prevent this naturally from happening. So remember, we first had platelet adhesion, then we have platelet activation, then we have platelet aggregation. So remember that here the platelets are now going to be attaching to each other and aggregating together to form what is known as a loose temporal platelet plug, or you can call it as a temporal hemostatic plug. And this temporal hemostatic plug is pretty much going to be closing the ruptured vessel and preventing any further blood loss that's going to be happening. And this process of platelet aggregation is pretty much going to be enhanced by a certain factor or a certain cytokine, which is known as platelet activating factor. Now, platelet activating factor is coming from neutrophils. It can be released from monocytes. It can also be released from the platelet cell membranes. Now, this platelet activating factor is the one that's going to enhance or accelerate platelet aggregation. Now, remember that this platelet aggregation is actually going to set off a series of reactions that are present inside the platelets in order for them to now produce thromboxane A2, in order for them to produce prostaglandins. So let me just show you a white screen here so that I can explain to you where this thromboxane A2 comes from. My bad. So, okay, let's go with the white screen. And we shall use black ink. So, pardon my handwriting. So let's say we have a platelet that has been aggregated and activated. Remember that platelets have phospholipids in them. So I shall say PP for the phospholipids. Now within these platelets, you have an enzyme which is known as phospholipase A2. Now this phospholipase A2 is going to be breaking down some phospholipids into arachidonic acid. So I shall abbreviate this as AA. So it's going to break down this into arachidonic acid. And this arachidonic acid can enter one of two pathways. It can enter a pathway which is referred to as the cyclooxygenase pathway, which is catalyzed by two main enzymes. There's what is known as cyclooxygenase 1, which I shall abbreviate COX-1, and there's what is known as cyclooxygenase 2, which I shall abbreviate as COX-2. Now, you ask me, why do you have two different types of enzymes? So one of the enzymes is what is known as a constitutive enzyme, meaning it's always working at some level. And then the other enzyme is inducible, meaning that it only works when you're in certain scenarios. So COX-1 is a constitutive enzyme. You can think of it kind of like the intern at the hospital that is always working. And then COX-2 is like the consultant that only gets there when they are needed. So usually in inflammatory processes and other scenarios. So whichever enzyme it may be, COX-1 or COX-2, this is going to result in now the synthesis of prostaglandins. Remember that these prostaglandins are going to be essential for production of the mucus and bicarbonate in the stomach. They're going to be responsible for the vascular tone of the afferent arterial inside the kidney. So you produce some prostaglandins, and then you produce another special type of prostaglandin, which is known as a PGI2. This is specifically known as prostacyclin. So this is where the prostacyclin is coming from. And the third thing that you're going to be producing is thromboxane A2 or TXA2. So this is where the thromboxane A2 is coming from. So this is the cyclooxygenase pathway. Then there's another pathway here in which this arachidonic acid could take. This is known as your lipoxygenase pathway, which is catalyzed by the your lipoxygenase enzyme. So this lipoxygenase pathway is going to produce what are known as leukotrienes. So these leukotrienes are actually going to be implicated in various things. They can cause bronchoconstrictions. They can also bring about these reactions that we see with inflammation. But then in some individuals, especially in individuals that are at risk of having a myocardial infarction, we could give them a drug that's known as aspirin to prevent this myocardial infarction. So if we give this person aspirin in a very low dose, about 75 milligrams that they take orally once a day, so this aspirin is simply going to come and inhibit these enzymes. So if this aspirin inhibits these enzymes, then you won't be able to produce prostaglandins, you won't be able to produce prostacyclins, you won't be able to produce thromboxane A2. And remember that thromboxane A2 is needed for the aggregation of platelets and activation of platelets. So if thromboxane A2 isn't there, then platelets can't be activated or aggregated, which is why aspirin is going to be considered as an antiplatelet drug. And that's why we give it in patients who are at risk of developing a myocardial infarction, or in patients who have had a myocardial infarction and you want to prevent any further complications. So I'll keep this in mind and have this diagram in your mind so that it will help you realize where the thromboxane A2 and the prostacyclins are actually coming from. So let's get back to our presentation. So remember that you have this thromboxane A2 and prostacyclin. I've explained where they come from, and our clinical sidebar with this is that aspirin is going to prevent platelet aggregation by inhibiting formation of thromboxane A2. So when we give it in low dose at 75 milligrams once a day orally, it's going to prevent a myocardial infarction because it will prevent platelets from actually accumulating and blocking the coronary vasculature, so that the heart will not be able to receive its oxygen supply through the coronary vasculature. And when it's not, then the heart muscle begins to die. When that dies, then your heart isn't really working well. Then you refer to that as a myocardial infarction. Now, after you these platelets have now adhered and they have now aggregated, what you simply form is what is known as an initial platelet plug. And remember that this initial platelet plug initially is going to be quite loose, but if the injury is very small enough, like I told you, the bleeding may actually be arrested before you actually even initiate the coagulation cascades. So it largely depends on the extent of the injury that is there. I've already explained where the prostacyclin is coming from. Is pretty much the membrane phospholipids, and this prostacyclin is going to be inhibiting the formation of thromboxane A2, and so this prostacyclin kind of acts like the brake to this system. So once you inhibit the thromboxane A2, you inhibit further aggregation and further adherence of an activation of platelets. So it means that you prevent further reactions that are going to cause platelets all over to keep aggregating until you use up all your platelets. So this kind of like localizes the blood clot so that it doesn't propagate to other areas or spread to other areas in the intravascular space. Now remember that platelets have three main types of granules, but I want you to remember these two main types of granules. They are what are known as alpha granules, as well as what is known as dense granules. You also have lysozymes, just like any other cell. So the lysozymes just pretty much have hydrolytic enzymes, while the alpha granules are going to have many things. They're going to have insulin-like growth factor, they're going to have platelet-derived growth factors, they're going to have transforming growth factor beta, they're going to have platelet factor 4, which is also known as heparin-binding chemokine, they're going to have clotting proteins such as thrombopoietin. You also have a fibronectin, as well as factor 5, as well as a von Willebrand factor. The dense granules are going to be having ADP, They're also going to be having ATP, adenosine triphosphate. They're going to have ionized calcium. As we shall see, calcium is very important in coagulation of blood. And then they also have serotonin, which is a potent vasoconstrictor. Remember when you said ADP and serotonin are going to be causing the initial vasoconstriction? Well, they're coming from the dense granules, which are found in the platelets. Now remember, up to this point, we've talked of the first two steps. We've talked of the initial vasoconstriction, then we have also talked of a formation of the initial platelet plug. So let me just show you a whiteboard once again, so that I could further beat this point to death, so that by the end of this lecture, you understand everything that is going on. So let's say you have a platelet here, or a blood vessel there, and then you have an injury that has happened here. You have another injury that has happened here. So now when you have this injury that has happened here, what you expose here is your subendothelial collagen. So you have a subendothelial collagen that you have expressed, and on the surface of this subendothelial collagen you have some molecules of von Willebrand factor that are going to accumulate there. So remember that this von Willebrand factor is what's going to be forming the bridge between the platelets and the surface of the collagen. So the platelets have a glycoprotein which is going to attach to this von Willebrand factor. So this platelet will have a glycoprotein that's going to be attaching to this von Willebrand factor, and then there are also going to be another glycoprotein that is pretty much going to attach to other platelets. So there's going to be interaction with another platelet. Now this attachment of this glycoprotein to other platelets is further advanced or further enhanced through the presence of ADP, such that now you form this network of these platelets that are attached to each other, and what you have formed now is what is known as your initial platelet plug. So what I'm circling right now here is known as your initial platelet plug. At the same time, after you form this initial platelet plug, this initial platelet plug has to be converted into a definitive hemostatic clot. Now the process of converting this into a definitive hemostatic clot is what is known as blood coagulation, which is what we're about to talk about now. So remember that blood coagulation is the process of converting soluble fibrinogen into insoluble fibrin. Remember that the fibrin strands are going to be attaching to this loose platelet plug, and they're going to be blocking the ruptured blood vessel and also preventing any further blood loss. So remember that for blood to actually clot, you necessarily do not need red blood cells, you do not need white blood cells, maybe platelets to some extent, but you could also do without them. Blood would still clot without platelets, though not effectively. Then it largely just depends on the clotting factors. So this is where we're going to be talking about the clotting factors. We're going to be talking about the clotting cascades. So this is where all the havoc usually comes in. This is where Pandora's box is for most students. So what I've talked of so far, to remind you, you first have injury to a blood vessel and damage to the endothelium. You expose subendothelial collagen. Von Willebrand factor goes and accumulates there. Then this leads to platelet adherence and activation of platelets. Remember, platelets are going to be producing serotonin. Serotonin is what is responsible for the initial vasoconstriction. The platelets are also going to be producing ADP and thromboxane A2. And in the presence of platelet activating factor, cause aggregation and activation of other platelets, which is eventually going to form your platelet plug formation. And then of course these activated platelets are eventually going to form prothrombin activators, which activate prothrombin then into thrombin. Then thrombin is going to convert fibrinogen into fibrin, and then this is going to form a blood clot, which is your step 3. So we are here at step 3. So some timings that you really need to know before we actually go into the details of the clotting cascades and the clotting factors. Remember that the process of coagulation is going to be consisting of a complex cascade of reactions, and these reactions are going to be involving the clotting factors, which I shall talk about very shortly. And remember that for blood to clot, usually it begins about 15 to 20 seconds if the trauma is actually very severe to the wall. It's very quick if it's very severe, but if it's minor, you could actually take about 1 to 2 minutes. And I think this makes sense to me, because if you think about it, if there's a very, very severe injury, there's a greater chance for you to lose more blood. So you should start this process very quickly. But if the injury is not so large, then you could pretty much buy in some time to actually kick in these processes. But within about 3 to 6 minutes after you rupture the blood vessel, the entire opening is actually blocked, or the end is actually blocked by a blood clot. That's if the opening isn't too large enough. And then usually after 20 minutes to about an hour, the clot retracts. And of course, this clot retraction is a component or is a property of platelets. That's why I said if platelets aren't there, then coagulation of blood is not as effective. So here's a diagram to help you relate to what I'm talking about. So here you have a severely injured vessel. Then you have platelet agglutination or adherence. Then you have fibrin appears, and then of course you form this fibrin clot. Then of course this clot retracts so that you do not completely block the lumen, and also you could begin the process of repair. So some clotting factors that we'll talk about before we talk of the clotting cascades. Remember that these clotting factors were either discovered by certain people, that's why they'll have certain names, or they'll depend on how they work, so as the activity of the clotting factors, or pretty much they'll be named after the patient in whom it was discovered. Like for example, factor 9, which is known as Christmas factor, was discovered in a patient who was by the name of Christmas, which I think must have been a very weird name. Hello, Mr. Christmas. But anyways, there are about 13 clotting factors that you really need to know, but remember clotting factor 6, the presence hasn't been proven, so it doesn't exist, so you can forget about clotting factor 6. And we write clotting factors as Roman numerals. We don't write them as numbers. Please do not write them as numbers. Write them as Roman numerals. As you shall notice throughout this entire lecture, I wrote them as Roman numerals. And remember that these clotting factors are usually inactive, because if they were actually synthesized in an active form, it means that your blood will always have a tendency to clot inside the blood vessels. But one mechanism in which the body has put into play to prevent this from happening is to actually synthesize these clotting factors in an inactive form. So usually they are synthesized as proenzymes to actually prevent your blood from clotting, and when they're activated, then you simply put an A in front of the clotting factor. Like for example, if you're talking of activated clotting factor 2, it would be 2A. If you're talking of activated clotting factor 10, it would be 10A. And remember that some of these clotting factors are actually synthesized in the liver. Most of them actually are synthesized in the liver, and there are some that are going to be dependent on vitamin K for the synthesis. Remember, vitamin K, we could get it from the diet. We could get vitamin K from our gut normal flora. There are certain bacteria in the gut that actually produce vitamin K. Remember that vitamin K isn't produced by the human body. There is no cell in your human body that is intrinsically yours that can actually produce vitamin K. And remember that this vitamin K is needed for the clotting factors 2, 7, 9, and 10. So just keep singing the song 2, 7, 9, 10, 2, 7, 9, 10. And remember that those are vitamin K dependent clotting factors. It also synthesizes or is dependent on the synthesis of protein C and protein S, which are proteins that are needed in the fibrinolytic system, but we'll talk of that towards the end of this review lecture video. So what implication does this mean? Remember that vitamin K is stored in the liver, so it's a fat soluble vitamin, and it is synthesized by gut bacteria, so it means its absorption is dependent on fat and it's dependent on bile. So it means that if someone has a malabsorptive syndrome, they won't be able to synthesize they won't be able to absorb vitamin K, and if they do not have vitamin K, they'll have a vitamin K deficiency. So it means that they'll be lacking clotting factors 2, 7, 9, and 10. So it means that they'll easily bleed, and when they bleed, the blood takes a longer time to coagulate. So remember also that in children, the liver isn't well developed to store enough vitamin K, which is why we give newborn babies vitamin K. But it's not every child that's born in the hospital. So in some cases, you may get a child that's born outside the hospital and actually didn't receive vitamin K injection. So if this child didn't receive this vitamin K injection, then they may have this vitamin K deficiency and they won't have these clotting factors. They may have a condition which is known as hemorrhagic disease of the newborn, where they could actually be bleeding from the umbilical cord, or the umbilical stump rather, which you have already cut. And then in some individuals that have chronic liver disease, especially in patients that are chronic alcoholics, then they may have damaged their liver such that they are incapable of storing adequate amounts of vitamin K and even synthesizing these clotting factors. So this may lead to some bleeding disorders. So keep that in mind. We shall talk of bleeding disorders as a topic on its own. So here's the list of clotting factors. So let's go through each and one of them. So you have factor 1, which is fibrinogen, factor 2, which is prothrombin, factor 3, which is tissue factor, or you can call it thromboplastin or tissue thromboplastin. Factor 4 is ionized calcium, or you can just simply call it calcium. Factor 5 is Label factor, or you can call it proacelerin, or you can call it accelerator globulin. Factor 6 has not yet been proven, like I told you. Factor 7 is stable factor, or you can call it as procovetin. Factor 8 is antihemophilic factor or antihemophilic globulin. Factor 9 is Christmas factor or plasma thromboplastic component or antihemophilic B. Then factor 10 is Stewart-Prower factor. Factor 11 is plasma thromboplastin antecedent, or you can call it antihemophilic factor C. And then Hageman factor is factor 12, and fibrin stabilizing factor is factor 13. Factor 12 is also referred to as contact factor or glass factor. And then this factor 13 is also referred to as fibrinase, or you can call it as Lackey-Lobrand factor. As you can see why this is a Pandora's box, because this already on its own is a mouthful. So it makes it very easy to remember if you actually have a mnemonic. So a mnemonic that you could actually remember that could help you remember these clotting factors is this. But one important thing that you need to note about this mnemonic is, please remember that factor 6 isn't there in this mnemonic. So this mnemonic doesn't account for factor 6. So you should skip factor 6. So the mnemonic goes like this: foolish people try climbing wrong slopes after Christmas. Some people have fallen. So the F here is for fibrinogen. The P here is for prothrombin. The T here is for tissue factor. The C here is for calcium. The L here is for label factor, and remember that factor 6 hasn't been proven. So the S here is for stable factor. The A here is for antihemophilic factor. This should have been in red. The C here is for Christmas factor. The other S here is for Stewart-Prower factor. The P here is for plasma thromboplastin antecedent. The H here is for Hageman factor, and the F is for fibrin stabilizing factor. And that's how you remember all 13 clotting factors. So take some time to actually absorb this and find some time to know this, because it's not just enough to know that there are 13 clotting factors and then you know them as Roman numerals. You should actually know what they stand for and their names. So there are also other clotting factors, things like a high molecular weight kininogen. We shall see how it's important in coagulation, a prekallikrein as well as kallikrein factors. You also have some platelet phospholipids. So here's a high yield table where I've listed the details of each of the clotting factors. So I will leave a link in the description with this PowerPoint presentation. So please go to the site, download the PowerPoint presentation, go through this table, and actually understand each and every section of this. And I think this is pretty much self-explanatory, and everything that is on this will make so much sense when you read through it slowly. So this is pretty much just talking about all the clotting factors and their role, and there are also some clinical vignettes that are there, but with the clinical vignettes and the clinical correlations we shall do when we look at bleeding disorders as a chapter on its own. So here is the last bit of this, so let's continue with our coagulation. So remember that there are two main substances that there are substances that could enhance coagulation. You call those as procoagulants, and there are also substances that could inhibit coagulation. You refer to those as anticoagulants. So how exactly is this sequence of clotting happening? Remember that clotting means the same thing as coagulation. Clotting is a process of conversion of fibrinogen into fibrin, or where you change the blood from it being liquid to it being jelly-like. So remember that these clotting factors are synthesized as proenzymes, and they must be activated to actually enforce the clot to form. And remember that this activation actually happens in a sequence where a proenzyme is activated into an enzyme, then it activates another proenzyme, then it's activated into an enzyme. So it kind of like works like a waterfall. So you first have the first series of enzymes that are going to be activated and converted into active enzymes. Then this first enzyme is going to activate the second enzyme. Then the second enzyme is going to activate the third enzyme. So you can think of it like a waterfall. So that's why it's known as a cascade, because a cascade is just simply going to be a process that's going to be occurring through a series of steps. And each of these steps is going to be leading to the next step, or initiating the next step until a final step is released. That's why we call blood coagulation the clotting cascades. So you pretty much have three important pathways. You have an extrinsic pathway, which is simply going to be activated when you have trauma and exposure of subendothelial collagen and release of tissue factor, which is factor 3. Then you have an intrinsic pathway, which is simply also exposure of subendothelial collagen in the presence of high molecular weight kininogen, as well as factor 12. So the intrinsic pathway is way much longer than the extrinsic pathway, okay? But both of these pathways converge on the spot. So I want you to keep in mind X marks the spot, okay? Because the goal of these two pathways is to get to 10. So the goal is we should get to 10. So 10, from 10 downwards, that's the common pathway. So X marks the spot. Keep that in mind. So there are three important steps that we need to discuss. When it comes to blood clotting, you have formation of the prothrombin activators, and then once these prothrombin activators are formed, they're going to convert prothrombin into thrombin, and once thrombin is formed, thrombin is going to convert fibrinogen into fibrin, and then that's what's going to form the definitive hemostatic clot. So in essence, you can think of it as two pathways that converge on a common outcome. So an extrinsic pathway, an intrinsic pathway, and a common pathway. So collectively, the clotting cascades are both extrinsic, intrinsic, and then they converge on a common pathway. So which is X marks the spot. So here I'll first show you a whiteboard and then explain everything about the clotting cascades so that we could work through it. It's easier to work through it than it is for me to just give you the information and then you just simply read. So if you are still enjoying these videos and you still haven't subscribed to the channel, and show some support by dropping a like or a comment so that we could keep making such videos. So remember, our goal here is to get to X. So here our case is X is marking the spot. So we shall draw our X here in the center of the screen. So remember that in the intrinsic pathway, you have blood vessels that are being ruptured, and these blood vessels are going to be exposing subendothelial collagen. So whenever this subendothelial collagen comes into contact with factor 12, so you have factor 12, which I shall write here at the top of your screen there. So whenever this comes into contact with factor 12, which happens to be Hageman factor, in the presence of kallikrein as well as high molecular weight kininogen. So I won't write kallikrein and high molecular weight kininogen because that's going to make this diagram very, very messy. So just keep that in the back of your mind, that in the presence of high molecular weight kallikrein, in the presence of high molecular weight kininogen, there are also some inflammatory reactions that could actually activate factor 12. So you're going to have factor 12 is being activated. So remember that we're working like a waterfall. So it means that if factor 12 is activated, the next thing factor 12 is going to activate is factor 11. So you're going to activate factor 11. So factor 11, inactivated factor 11 is going to be activated into activated factor 11 here. Remember, we add an A in front of these and we write them as Roman numerals. And remember, high molecular weight kininogen is needed for this, which I shall just abbreviate as HMWK. So high molecular weight kininogen, in the presence of this, factor 12 is going to be activating factor 11. But remember, from factor 11, we say that this pathway is much longer than the extrinsic pathway. This is the intrinsic pathway, which I shall abbreviate as an I here. at the corner of your screen. And then extrinsic pathway, I shall write it here as an E at the corner of your screen over there. So remember that this pathway is much longer, so we can't just go from 11 to 10. So we'll skip 10 for now, and then we go to 9. So remember that factor 11 here is going to now activate factor 9. So this is going to activate factor 9. We come from 11, we skip 10, then we come to 9. So this is going to be activating factor 9. Okay, so for this factor 9, for this process to happen, calcium is a very important thing to be present. So factor 4 is also going to be present here. So this is going to be in the presence of factor 4. This is factor 4, not an IV line. For those people that are in the clinicals, this is factor 4. So in the presence of factor 4, this is going to activate factor 9. Okay, now factor 9 together with factor 8, which is antihemophilic factor, together with factor 4, which is calcium. So this here, okay, together with some phospholipids, so you have factor 9, which is activated here in the presence of factor 8, in the presence of factor 4, which is calcium, in the presence of some phospholipids, is going to activate. So all this here is going to lead to the activation of factor 10. So this is going to lead to activation of factor 10. Okay, so remember X marks the spot. So up until we reach this point here, this is the common pathway where factor 10 is. So this is the extrinsic pathway. Okay, I'll explain the common pathway when I explain everything in total. So I'll leave the intrinsic pathway at this point where factor 10 has been activated. Then remember that these phospholipids, where are these phospholipids coming from? Remember that when the platelets are coming into contact with the subendothelial collagen, they get activated and they're going to release these phospholipids. So this is where these phospholipids are coming from. Then on the other hand, here you have some trauma that is causing damage to the tissues. So you have trauma here. Again, apologies for my handwriting. I'm using a touchpad for this, so it's a bit difficult. So after you have trauma here, you're then going to be producing factor 3, which is tissue factor. So factor 3, activated factor 3 is going to be released. So this one is pretty easy. So remember that factor 3 here is going to be consisting of proteins, it's going to be consisting of phospholipids, it's going to be consisting of glycoproteins that are pretty much going to be acting as a proteolytic enzyme. So this factor 3 in the presence of factor 7, so this in the presence of factor 7 is going to lead to activation of factor 10. That's about pretty much it. So remember that this also is going to require some phospholipids. Okay, now these phospholipids that are being produced here are being released from the damaged tissues. They are also part of the thromboplastin phospholipids, and that is where these phospholipids are coming from. So whatever the case it may be, you have this factor 10 that has been activated. So remember that factor 10 now, in the presence of phospholipids, depending on wherever the phospholipids are coming from, in the presence of calcium, so this is going to be what is known as a prothrombin activator. So this complex here that you have formed is known as a prothrombin activator. This is going to activate factor 5. So this is going to be activating factor 5. Okay. Oh, sorry, this is going to be activating factor 5 into factor 5 there. Then this factor 5 is going to be added to this complex here. So this complex here together with factor 5, this is going to lead now to the activation of factor 2, which is prothrombin, into thrombin, which is activated factor 2. Then prothrombin is pretty much going to be converting fibrinogen, which is factor 1, into fibrin, which is activated factor 1. And then the fibrin will eventually polymerize, and in the presence of the last factor that we haven't talked about, which is factor 13, is eventually going to be forming a definitive hemostatic clot. So remember that in this common pathway, the most important things or most important landmarks is factor 10, factor 5, factor 2, and factor 1. So I could have an equation for you here. So 10 is going to be equal to 5 multiplied by 2 multiplied by 1. So if you multiply 1 by 2 by 5, it gives you 10. So this here should be your common pathway. And remember that X marks the spot, and those are the coagulation cascades, and that's the clotting cascades. So now let's go through the text and see what I have to say for you. So remember, we have an intrinsic pathway, extrinsic pathway that converge on a common pathway. So remember that when blood vessel is ruptured, the subendothelial collagen that is exposed, and factor 12, which is Hageman factor, comes into contact with this collagen in the presence of kallikrein as well as high molecular weight kininogen. Then activated factor 12 converts factor 11 into activated factor 11 in the presence of high molecular weight kininogen. Then activated factor 11 activates factor 9 in the presence of calcium, and then factor 9 activates factor 10 in the presence of factor 8, which is antihemophilic factor, and factor 4, which is calcium. And then when platelets come into contact with the subendothelial collagen, it gets activated and releases phospholipids. So we take a pause here and we'll discuss the extrinsic pathway. So in the extrinsic pathway, you have damage to the tissues that are going to be releasing factor 3. Remember, factor 3 is going to be containing proteins, is going to be having phospholipids, it's also going to be having glycoproteins that are pretty much going to be acting as proteolytic enzymes. And this is going to activate factor 7 in the factor 10 in the presence of factor 7. So here's a diagram to explain everything that I've been telling you about. So you have endothelial damage here. Factor 12 activated factor 12. Factor 12 activates factor 9. Factor 9 activates factor 12 activates factor 11. Factor 11 activates factor 9. Then factor 9 in the presence of antihemophilic factor, which is factor 8, and calcium activates factor 10. Then on the other hand, here you have tissue and trauma that's going to be producing factor 3, so tissue factor. Then the glycoproteins and phospholipids of factor 3 in the presence of factor 7 are going to be activating factor 10. Then this is now going to be converging into a common pathway. So in the common pathway, the activated factor 10 reacts with phospholipids or thromboplastin phospholipids and factor 5 to form prothrombin activator in the presence of calcium, of course. So prothrombin activator converts factor 2 to activated factor 2 in the presence of calcium. So this is a prothrombin into thrombin. Then you also have to take note that factor 5 actually is also activated by a positive feedback mechanism of thrombin. So if you make thrombin is going to go back and activate even more factor 5 so that you can produce even more thrombin. So this is kind of like a positive feedback effect. And the thrombin is then going to be converting factor 1, which is fibrinogen, into fibrin. So initially you're going to be forming these fibrin monomers. For 2 polypeptides are going to be arising from each fibrinogen molecule, and then eventually we are going to polymerize to form these loosely arranged strands of fibrin. Then you have factor 13, which is fibrin stabilizing factor in the presence of calcium. That's obviously going to modify them into these dense and tight fibrin threads to form a meshwork of a stable clot. So remember, 1 by 2 by 5 will give you 10, and X marks the spot. So knowing this sentence just here helps you remember how to draw the clotting cascade, helps you remember how to explain the clotting cascade to anyone. And I think this should make the clotting cascade very easy for you to understand. So take note also of the positive feedback role of thrombin that, like I've already told you, it's going to accelerate the rate of formation of prothrombin by activating factors 8, factor 5, as well as factor 13. So thrombin can actually also convert prothrombin into thrombin, so you refer to this as an amplification effect. It's also going to activate protein C, because at the same time as you are like applying the accelerator to the blood clotting, you also have to apply the brakes so that you prevent everything in the bloodstream from clotting. So it also activates protein C, which is an anticoagulant. So here's a diagram to summarize everything that I've been talking about. So on this end here you have the intrinsic pathway. On this end here of the extrinsic pathway, as you can already see, the intrinsic pathway is much longer than the extrinsic pathway. Then eventually, so the first step here is the formation of a prothrombin activator, which we have formed. Then the prothrombin activator is going to be converting prothrombin into thrombin. Then of course thrombin is going to be converting fibrinogen into fibrin. These are the 3 steps that are involved in blood coagulation, and the 3 pathways that are involved: intrinsic pathway, extrinsic pathway, and of course a common pathway. So remember that the blood clot is going to be consisting of red blood cells, white blood cells that are pretty much trapped in the meshwork, as well as platelets. And the red blood cells and white blood cells, we actually don't need them, and blood clotting could actually happen without them, but they just get trapped with the platelets. And the trapped red blood cells actually what are going to be giving the blood clot its red color. And remember that external blood that has clotted forms what is known as a scab, and this scab usually tends to adhere to the opening of the damaged blood vessel, and it's going to be preventing blood loss. So after now this blood has clotted, after about 30 to about 45 minutes, sometimes even as far as an hour, you get this straw-colored serum that actually oozes from the clot. So now this straw-colored serum, or this process of contraction of the blood clot and oozing of this serum, is what we refer to as clot retraction. Remember that this clot retraction is pretty much going to be due to the contractile proteins that are present inside the platelets. That's why I say that platelets are also essential for blood clotting, because they help in clot retraction. So things like actin, myosin, thrombostenin are actually present in cytoplasm of platelets, and they are responsible for the clot retraction. And remember that if this clot is actually kept for several hours, the clot is actually going to retract to about 40% of its original volume. This is a very important aspect. They may ask you this on your MCQ questions. And of course the clot retraction is impaired if the platelets have been removed. So why is calcium very important for us in blood coagulation? Remember that it's very vital for the first 2 steps of the intrinsic pathway, and it also promotes virtually almost all the reactions of the clotting cascade, as we were already seeing that all those reactions were happening in the presence of calcium. So it means that if we remove calcium from the solution, then, or from blood, then blood will have an inability to actually clot. So if blood has an inability to clot, that means that we can actually take advantage of this. Like for example, if we decide to draw blood from an individual and actually store it in a blood bank for people that may need a blood transfusion, then we could actually remove the calcium ion so that we could actually keep the blood in a refrigerator. I don't know what's happening to my English. Refrigerator, to prevent it from clotting. Then of course this is done with some anticoagulants such as oxalates as well as citrates. Then remember that in humans you may sometimes have a low level of calcium, such as a hypocalcemia. This may be due to vitamin D deficiency or hypothyroidism, but then this, which is compatible with life obviously, is not low enough for you to have bleeding disorders. So that's why we don't really see people with vitamin D deficiency having some bleeding disorders. We may sometimes see this with vitamin C, but that's with scurvy, and that's a story for another day. Then you also have vitamin K, which is very important. As I already told you, vitamin K is derived from the food. It's also synthesized synthesized by bacterial flora in the gut, and it helps in the liver in the synthesis of clotting factors 2, 7, 9, and 10, as well as protein C and protein S, meaning that the liver also has a very important role in blood coagulation. The liver is going to be synthesizing some clotting factors. It's also going to be synthesizing some anticoagulant factors, as well as the storage of vitamin K, obviously. Then remember that nothing lasts forever and everything has to come to an end. Even this video at one point will come to an end as we actually move towards the end. So you can't keep coagulating your blood forever, otherwise all your blood throughout the body is going to form a blood clot. So you remember that a fibrinolytic system has to be put into place, and remember that this process of fibrinolysis is just simply lysis of the blood clot inside the blood vessel. So it helps to remove the blood clot from the lumen of the blood vessel, and it actually requires a substance that's known as plasmin or fibrolysin. So you ask me, why fibrolysis? Why is it needed? So one of the reasons is that it's going to be helping in cleaning out the minute clots in tiny blood vessels. Remember that this fibrinolytic system is constantly working, and it's working much more than the fibrin, because there are some portions of your blood that actually do clot and form these small clots, but if these small clots aren't really controlled, they may actually escalate and lead to other bigger things, which you shall see later on. And the second reason is that it's going to be promoting normal healing. So remember that lysis of this clot is going to, as a result of the tissue injury, actually helps with the normal healing process. It helps you with the process of revascularization and repair to the damage that has been caused to the injured blood vessel. The third thing of fibrinolysis is very important in the menstrual cycle, because it causes a liquefaction of these menstrual clots in the vagina, and for them to be actually passed out much easier. Then the fourth thing is that it's also going to be essential for liquefaction of sperms in the epididymis, especially when there's a seminal ejaculation doesn't occur. Then this is caused by the fibrinolytic system. Then the fifth and final thing is, of course, through the inflammatory response. Remember that in addition to the fibrinolytic activity, plasmin can actually form some kinins like bradykinins, kallidin, and this can actually be contributing to vascular changes as well as some sensory features like pain that we see in the inflammatory response. So these are just some of the 5 good reasons why we need fibrinolysis in our body. So how exactly does this system work? Remember that this is based on plasmin, so you have to form plasmin. So plasmin is not always present in the blood. It's also formed as an inactive compound, which is known as plasminogen, which is synthesized from the liver and of course incorporated into the blood clot. So this glycoprotein has to be converted into plasmin. Now, what converts plasminogen into plasmin is what are known as plasminogen activators. So you could have tissue plasminogen activators, which is obviously going to be derived from damaged tissue. You have some lysosomal enzymes. You also have thrombin. Remember, thrombin also activates plasmin. So it can activate plasminogen activators that are going to activate plasminogen into plasmin. So remember that tissue plasminogen activator and lysozymes are going to be released from damaged tissue as well as endothelium, whilst thrombin is going to be derived from the blood. Then this tissue plasminogen activator always inhibits or is always inhibited by a tissue plasminogen activator inhibitor. It's also inhibited by certain clotting factors like factor 5 as well as factor 8. Then you also have another type of plasminogen activator, which is known as urokinase plasminogen activator, and of course this is derived from the blood. So you have 2 important types: tissue plasminogen activator as well as urokinase plasminogen activator. So remember that now blood has clotted and you want to get rid of this blood clot, because it's not going to stay there forever, because it will block the blood flow, and whenever blood is blocked by a clot, then you're going to have ischemia or death of tissue everywhere where this blood vessel is supposed to be supplying. So when there's intravascular clotting, then the endothelium is going to be secreting a molecule, a thrombin binding protein, which is known as thrombomodulin. So this thrombomodulin is secreted virtually from all the blood vessels except from these small blood vessels that are found in the brain. So this thrombomodulin is going to be binding to thrombin to form what is known as a thrombomodulin thrombin complex. Now this thrombomodulin thrombin complex is going to activate a protein which is known as protein C. Protein C is also another protein that's vitamin K dependent and is synthesized in the liver, and activated protein C is pretty much going to inactivate factors 5. It's going to inactivate factor 8 in the presence of protein S. So if you inactivate factor 5, it means you have killed the common pathway. If you inactivate factor 8, it means that you have killed the common pathway, and you have killed virtually intrinsic pathway. Then remember that protein C is also going to inactivate the tissue plasminogen activator inhibitors. So it means that tissue plasminogen tissue plasminogen activators are no longer going to be inhibited. So they become active, and together with some lysosomal enzymes, these are going to be now converting plasminogen into plasmin. So the whole goal of this was to form plasmin. Then of course, the plasminogen can also be activated by thrombin. It can also be activated by urokinase plasminogen activator. Then the plasmin that has been activated is pretty much going to be breaking down fibrin into fibrin degradation products, and then this fibrin degradation products could inhibit thrombin to prevent any further blood coagulation and to cause fibrinolysis or removal of the blood clot. So clinical sidebar with this, we can actually tell that a blood has clotted in your body. Like for example, in someone who has a deep vein thrombosis, where they form this intravascular clot in the deep veins of the legs most commonly. So remember that whenever blood is clotting, the fibrinolytic system is also set into cascade. So once you have this fibrinolytic system that is activated, you produce these fibrin degradation products, which we can actually measure for in the blood. So if they reach a certain level, then we're pretty adamant that this person actually had a blood clot in their system. So we could use this to actually make your diagnosis of a deep vein thrombosis. Then we could also use certain bacterial enzymes such as streptokinase as well as staphylokinase, because these are actually going to be producing activation of plasmin, just like with tissue plasminogen activator as well as urokinase. And we can actually use this to treat early myocardial infarctions. Like for example, if you have a blood clot that is blocking the coronary vasculature in the early phases, usually in the first hours, specifically I think it should be 3 hours if I'm not mistaken, then we could actually give these drugs, and this drug could actually lyse the clot and actually lead to reperfusion of the heart muscle and prevent the heart muscle from dying. So here is a summary of the fibrinolytic system. So you have damaged tissue and the endothelium releasing lysozymal enzyme as well as releasing thrombomodulin. Remember, thrombomodulin binds with thrombin to form a thrombomodulin complex, thrombomodulin thrombin complex. Then this is going to activate protein C, and once protein C has been activated in the presence of protein S, is going to lead to inactivation of the tissue plasminogen activator inhibitor as well as inactivation of factor 5 and factor 8. This is going to lead to activation of tissue plasminogen activator, which is of course going to be activating plasminogen into plasmin. Then this is going to be degrading fibrin into fibrin degradation products, and that's how the fibrinolytic system works. So why then doesn't blood clot in our system, you ask me? There are many reasons why, but I'll give you the most important reasons here. So one important reason is that this blood is constantly moving, so there's a velocity to the blood. So the blood is in constant motion, so this actually contributes to its fluidity. This is actually supposed to say fluidity over here, and any decrease in this velocity is actually going to lead to stasis, and this stasis can actually lead to intravascular clotting. So if you have any condition that is causing stasis of blood, this is going to now cause blood to clot. Then sometimes the surface effects of the endothelium, remember that the endothelium is smooth and glistening, so it means that the platelets do not get a chance to actually be activated or adhere. The endothelium also produces certain factors that are anticoagulant, things that stop coagulation. In addition to this, the endothelium is intact, so meaning that there is not going to be some exposure of subendothelial collagen to activate the platelets or to cause von Willebrand factor to accumulate. And of course, the endothelium has these glycocalyx, which are simply mucopolysaccharides that are negatively charged. Remember, at physiological pH, the endothelium is going to be negatively charged, the proteins are going to be negatively charged, and the clotting factors are proteins, so they are anions, so they're going to be negatively charged, and the platelets also are negatively charged, so negative and negative repel. So these are some of the factors that the endothelium has to prevent your blood from clotting. Then of course there are some circulating anticoagulants such as heparin, which is produced from mast cells and basophils. You also have antithrombin 3, which is a protein which we'll talk about. You have alpha-2 macroglobulin. You also have protein C, which we have already talked about, as well as the fibrinolytic system, which we have talked about. And of course the liver removes the activated clotting factors, because you would ask me, where do they go once they have done their job? The liver gets rid of them. So these are the reasons why your blood actually doesn't clot under normal circumstances. So if your blood were to actually clot within the blood vessel, if you were to form an intravascular clot, then you refer to that as a thrombosis. So there are three main factors that increase your chances of you having a thrombi forming within your bloodstream. So the first factor is endothelial damage. If you have endothelial damage, you have exposure of subendothelial collagen. So you have conditions like atherosclerosis, where you have deposition of fat in the walls of the blood vessels and the walls actually thicken and harden. You could also have some hemodynamic stress that is due to hypertension. Because of the high blood pressure, you could have damage to the endothelium. You could also have arterial disease, of course, damage to the endothelium, diabetes mellitus, which also causes damage to the endothelium, as well as hypercholesterolemia, leading to activation and aggregation of platelets. You could also have stasis of blood. So in patients that actually spend a lot of time sitting, like for example, depending on your occupation, like for example, if you're an office worker or a truck driver, or if you're on a long flight, you could even have gone for a major operation and you could be post-op, meaning after the operation, and you're bedridden. So with bedridden patients, because they're not moving, their blood tends to pool and it can easily clot. And then one important thing is atrial fibrillation, where the heart actually fails to actually contract because each of the individual muscle fibers are contracting on their own and the heart isn't contracting as a whole. So this blood actually can pool in the heart and actually form a blood clot. Then sometimes you could have hypercoagulability, where you could have conditions that increase your clotting factors, like someone for whatever reason produces a lot of fibrinogen or produces a lot of thrombin or produces activated factor 6, factor 7, as well as factor 10. Someone could have a high platelet count. Remember that the platelet count is between 150,000 to about 400,000 cells. And then sometimes you could have increased the adhesiveness of platelets, or you could have decreased in some coagulation inhibitory factors. Like for example, if someone is losing the proteins, like for example in nephrotic syndrome, which is a condition of the kidneys where someone is losing their proteins in the urine, they could lose antithrombin 3, and this could actually predispose them to have their blood clotting. So these three factors, endothelial damage, stasis of blood, as well as hypercoagulability, you refer to that as Virchow's triad. I don't know how some people pronounce this word, but I pronounce it as Virchow's triad. So what are the effects of youth forming this thrombi, and how do we prevent it? So if you have a thrombi blocking a blood vessel, like for example, if it's blocking the coronary vasculature, which supply the heart muscle with enough oxygen so that the heart muscle doesn't die, you could lead to death of the heart muscle, which you or decrease or blockage of blood supply to the heart muscle, which we call myocardial ischemia. And of course, if this blockage isn't relieved, it may lead to death of the heart muscle, which is known as myocardial infarction. In layman's terms, it's referred to as a a heart attack. Then you could also sometimes have thromboembolism, where you have this clot that forms in an area, and then this clot is dislodged and carried by the blood vessels to an organ which has very small blood vessels, where it can actually block these small blood vessels. So the two most important areas are in the lungs, so you could have a pulmonary embolism, or in the brain, you could have a cerebral embolism. So how do we prevent this? We could actually decrease the number or the adhesiveness of the platelets by giving aspirin. I've already explained how aspirin works. You could also give dextrans, or you could give dipyridamole. But from these three drugs, please no aspirin, because that's the one that's much more commonly used in our setting. Dextrans as well as dipyridamole, you don't use it routinely. Then anticoagulants like low-dose heparin, which we use. We could also use dicumarol. You could also perform intermittent compressions or electrical stimulation of muscles, especially in post-op patients, to prevent venous thrombosis. So you could actually advise the patients to get what are known as compression socks, which actually squeeze the muscles and they push the blood so that the blood doesn't pool in the periphery. So remember that we talked of compounds that are going to be inhibiting coagulation, which I refer to as anticoagulants. So these anticoagulants could be endogenous or exogenous, so endogenous compounds like prostacyclins. I explained where this came from, as well as some circulating substances such as heparin, antithrombin 3, which is also known as heparin cofactor 2, as well as protein C, which I've talked of in the fibrinolytic system, as well as some exogenous things like heparin, calcium sequestras, some vitamin K antagonists, as well as defibrillation substances. So we'll talk of the ones that I haven't talked about. So beginning with heparin, so remember that this is a very powerful anticoagulant that was first discovered in the liver. That's why it's referred to as heparin. Heper meaning liver. Heparin, it's found in the liver. So remember, it can be found in other organs too. It can be found in cells. Two important cells are basophils as well as mast cells. Remember that these cells are found in the liver, they're found in the lungs, they're found in the respiratory tract, they're found in the gastrointestinal tract. So basically tissues that are rich in connective tissue. So remember that this is a polysaccharide that has many sulfate groups, and its molecular weight is about 15,000 to about 18,000 Daltons. And how does this heparin work? So there are three postulated mechanisms of action of how heparin works. So one mechanism is that it's going to prevent the activation of prothrombin into thrombin. Remember, if you don't have thrombin, then thrombin can no longer activate fibrinogen into fibrin. Then the second mechanism of action is that it's going to be inhibiting the action of thrombin on fibrinogen. Like I already told you, you're not able to convert fibrinogen to fibrin. But one important thing is that it works with antithrombin 3. It acts as a cofactor. So in the presence of heparin, antithrombin 3 actually inhibits factors 9, factor 10, factor 11, and factor 12. So once you have inhibited these factors, then you've blocked both the intrinsic pathway and the common pathway. So that is how heparin works. So we could use heparin for the treatment of DVTs. We could use heparin for the treatment of pulmonary embolism or preventing any blood clots in the body. Then antithrombin 3, remember that this is present in the plasma as well as the vascular endothelium. It's going to be inactivating factors 9, 10, 11, and 12, as well as thrombin. Then you could also have some calcium sequesters as well as decalcifying agents. So remember, these are going to be removing calcium as well as preventing blood from clotting. Remember, I told you that calcium is very important. Once you remove it from the blood, it doesn't clot. So there are two important substances. So the substances which actually facilitate the formation of these insoluble solutes, because the calcium that has to be present for coagulation has to be ionized. So if it's an insoluble salt, then it's pretty useless. So you could have salts of sodium citrate or sodium oxalate that could react with the ionized calcium, so that you use up the calcium and the calcium is not there to facilitate blood clotting. Or you could add what are known as calcium chelators. So these chelating agents are going to be pretty much binding calcium. You have one common example, which is known as ethylene diamine tetraacetic acid, or EDTA. This is actually what we use in those purple top bottles which they use to collect your blood. And once you put blood in that purple top bottle which has this compound, then this compound is pretty much going to be binding to the calcium and prevent your blood from clotting. So your blood will actually not clot within that purple bottle. Then sometimes you could have vitamin K antagonists. So these are usually taken orally, and they're going to prevent the synthesis of vitamin K dependent clotting factors. And remember, these are factors 2, 7, 9, and 10, as well as protein C and protein S. So some examples are dicumarol as well as warfarin. So warfarin is what we use. So in DVT management, we could use warfarin as well as heparin. Then you could sometimes have some defibrillation substances that are pretty much going to destroy fibrinogen. One example is a Malaysian pit viper venom. So remember, in the body, in vivo, in the body, it's going to stimulate the fibrinolytic system, so it will prevent your blood from clotting, which is a very bad thing, because once you now injure yourself, you keep bleeding. You could even start bleeding internally. This is one reason why people actually die. And then in vitro, when you're actually testing this, it has actually a direct anticoagulant effect on fibrinogen. It results in formation of these imperfect fibrin polymers. You could also have Avin or Ancord, which is pretty much a purified snake venom preparation, which also works in a similar way. So here's a very nice paradox that I will lead you into, and I'll leave this on your mind. So remember that if you've ever visited a blood bank before, cold temperatures actually are going to slow down the process of coagulation. So if you take blood and actually put or store it at a colder temperature, it will prevent blood from coagulation, which explains why blood banks are going to be storing their blood at a temperature of about 5 to 10 degrees. But then think of this. Whenever you're bleeding, yeah, and you get ice, and you apply that ice to stop the bleeding, remember that cold is supposed to delay coagulation. So then why are you applying the ice? And the funny thing is that if you apply the ice, the bleeding actually reduces. So in fact, you actually have the ice actually preventing bleeding by inducing this reflex vasoconstriction, which is what explains the paradox. But then it doesn't make sense in the fact that the cold should actually slow down coagulation and actually make the bleeding worse. So that's a paradox that you should actually think about. But remember that all this is because of the inducing the reflexive vasoconstriction to reduce the blood. So take note that we shall talk about the bleeding disorders as well as laboratory tests in a lecture that I'll do in internal medicine on bleeding disorders. So if you're still interested in learning that, aside from the physiology, please stick around. Share this video with a friend that you think it may help. And if it has helped you, please drop a like, drop a comment. Thank you for taking your time to listen to this review lecture video on blood coagulation and hemostasis. My name is Dr. Moses Kazevu. Until next time, bye-bye.